We have docs that want to just have more say in, hey, I want a nurse, not an MA, or I want 45-minute visits, or I want to do this. Like, I want my practice to focus on preventative medicine. So I think it's really exciting.
Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers Podcast. Excited to be sitting here today with the wonderful Jasen Gundersen. Jasen is the CEO and co-founder of Cardio1. Cardio1 has been making all the headlines recently for landing an incredible deal. And so congratulations, and excited to talk about it some more. But Jasen, thank you so much for joining us today.
Thanks for having me. Excited to chat about it.
So let's go back to the beginning. Where did you grow up, and how did you get involved in healthcare?
So grew up in Connecticut, down in the shoreline of Connecticut. Back when I was in second grade, I did some project, I think, on the heart, and I said, "Oh, I'm going to be a doctor." And so I actually pretty much stuck with that. So I really never deviated from the idea of ever becoming a doc. So grew up there, college and medical school in Connecticut, graduated from University of Connecticut School of Medicine, and then went off and did residency up with UMass, where I spent the first 10 years of my career. So
wow. I
don't know, somewhere along the way, I said I was going to be a doctor, and I never really, the idea of doing something different never really dawned on me.
That's amazing.
Being in healthcare business really never dawned on me, even when I was thinking about what I was going to do as a doctor.
Yeah. So, and kind of jump back forth a little bit, but you mentioned healthcare business, and I see this often. I think I've said this on the podcast a couple of times. Not that many doctors. Business is not really taught, obviously, in medical school, and you don't see that many doctors that are really good at business. But very often, the ones that are and turn out to be kind of unicorns and go really far. So, first, let's talk about the business side of it in medical school. What was your experience? Did you feel like you gained any kind of education on the business end, or not at all? What was your perspective?
Nothing in medical school. And I actually was pretty, UConn was a pretty progressive medical school, or one of the first schools that went to all the problem-based learning and away from just sitting in a classroom all the time. But yeah, there's no education on any parts of the business of medicine. I will say I went to medical school with the idea of being a rural primary care doc, and I trained with the UMass Family Medicine residency, and they actually have a course that they incorporate into the third year of residency training, which is the business of medicine. And we went out and visited practices. It's much more how do you just work, and what's a contract and some of the basics of it. But I had a little teeny tiny bit of it. But yeah, we don't train doctors in the business part of medicine at all.
Yeah. So for you personally, where did you start picking up on that kind of knowledge?
So after my first couple of years, I did a couple of years with the National Health Service and a federally qualified community health center. I was always a teaching doc. And the chair of the Department of Family Medicine, great guy, came to me and said, "Hey, we want to build a hospitalist program, and you're kind of always in the hospital, coming up with new ideas. Do you want to do it?" I didn't know what a pro forma was. I hadn't gone to business school. So I phoned a friend and called all my colleagues, and between Google and friends, cobbled together a pro forma, launched my first program. And it blew out of the park. We were super busy from day one. It took off. And then I figured along the way, I was like, I better learn something. So I went and I did my MBA in 2007. So a few years after residency, I went and did my MBA. It was interesting. I did my MBA at a program at the University of Tennessee. People were like, "Why there?" But they had one of the only physician-only MBA programs. So everybody that was there was a physician.
Interesting.
And it was helpful because your background is you're always a doctor, and so
right.
The types of roles and stuff are very different. So it was a great experience, and that's really where I learned a lot about more of the kind of fundamentals of finance and accounting and all the rest of it. And then, I think self-taught along the way is I've kind of broadened and head out and done different things.
Fascinating. So where did you go? So now let's jump to Cardio1. So what is Cardio1, and how did you come up with the idea? What was the path?
Yeah, so Cardio1 is a physician enablement platform that is specifically focused on supporting independent cardiologists. It's really difficult being a doc. So I like to say we solve for today and build for tomorrow. So we help independent cardiologists stay independent, solve for the challenges that they have, everything from EMR, revenue cycle, workforce management, marketing, practice optimization, basically everything but pay the doctors. With the goal of helping those practices kind of survive, do well today, and then build them into kind of the future of value-based care, right? And value-based care, if we asked 100 people for definitions, we'd probably get 3,000 answers. But really to kind of move cardiologists into a pay for outcomes type model. That's the program. Where did it come from? So in my former roles, I'd had a lot of experience and opportunity to work in pretty significant value-based care arrangements, full capitation, bundle payments, ACOs, and the rest. So always fascinated by kind of working with physicians to help them move into some of these models and get paid for kind of the outcomes that we do, not just on volume. And then looked around and said, hey, there are some pretty interesting programs going on in the kidney space and the oncology space. We'd known about musculoskeletal. I had a bunch of friends that worked for places like Health Map and US Renal or the Oncology Institute. And we kind of looked at it and said, well, cardiology is the number one cause of death in the United States. Lots of opportunity. That coupled with the fact that we were originally part of our initial investor and seed investor was Redesign Health based in New York City. And they had been working on a thesis around cardiology and value-based care. And so it kind of all came together where they found me, I was interested, we got together, built the program, and we launched in about a year and a half ago. Was when we launched the program officially. I've been with Cardio One for about a year and a half, all in.
Wow, what a wild story. So let's talk about kind of the seed funding stage, and this is kind of moving over to the business side of it and the entrepreneurial, founders side of it. But what was your framework around when and how to take money? It's a very hot discussion among founders. Yes, take money, don't take too much money, it can ruin you. If you take too little money, it'll ruin you. What's your lens on that entire conversation?
So we were part of a venture studio, so the money was part of it. And so we had it staged in like an initial tranche and then an acceleration tranche. So you had an initial proof of concept, and then when you had a proof of concept, you could access an additional round of capital to help you move forward.
Oh, interesting.
Taking money and not taking money. So I have a good friend of mine, used to be an account manager of mine at another company, launched an idea that I talked to her about. I mean, they bootstrapped the whole thing and they sold it to Iodine Software for like $100 million, and they made crap loads of money. Yeah, it was a phenomenal story. Artifact Health. Marisa McClary was one of my account managers. You got to get her. She's great. She's a friend of mine. Came up with this whole solution to solve clinical documentation in hospitals. It's a very annoying thing us hospital docs had to deal with. Yeah. And they really bootstrapped the whole thing, and then they exited to Iodine a few years ago. They did it the hard way. They bootstrapped it and really had to go at it. Taking money for us had the advantage of we were able to do something much faster because we had capital behind us. And frankly, had we had a little bit more capital, we could have gone even faster. And so I think that there's a balance in what you're trying to do between taking capital and how fast you can get to market. And in today's environment where healthcare moves really quick, you need to be on the pointy end of the spear. So I think, the capital we had and the relationship that Redesign provided enabled us to move very quickly. So we were able to scale, get people on board, launch, and clearly went from seed to an acquisition in essentially 15 months from our announcement to when we announced the close. So there's trade-offs to it, right? There's dilution that comes into it. Cap table gets more complicated. New investors have to kind of figure out how they want to deal with that. So you just have to balance that. I think it's an interesting conversation with folks. People get capital and they're like, worry about cash burn. We all worry about cash burn, but I tell people, people don't invest in you to see how long you can stretch their capital. They invest in you to see how fast you can grow their money. And so it's trying to figure out how to balance those. So I think investors have to figure out, like, everybody has to think about it from the standpoint of like speed to market and ability to execute. The thing that the worst thing you can do is go out, take money, and then don't execute, because
Right.
then you're in trouble.
They have the worst
Right.
of both. 100%.
Yeah.
100%. Fascinating. Wow. That's sound advice. So going back to the actual solution for a second. So first of all, yeah, like heart disease is by far the number one cause of death, right, in the country.
Yep.
What would be the first thing that you would do? So talking about preventive care for a second, which is a huge part of value-based care. So what would be some of the like initial preventive things that you would put in place to help a cardiology practice feel comfortable about assuming risk?
So I like to start with the simple stuff,
Sure.
because I think that's where we struggle the most. Access.
Okay.
Access is the key to everything. So whether you're in value-based care or you're in fee-for-service, um, if you or any of your listeners have tried to get a cardiology appointment for themselves or their family member, it sucks.
Yeah.
It takes a very, very long time.
Yeah.
And so as you think about it, so we need to make sure that we have appropriate access and utilization for our cardiologist. And so I think that's where we, like, when we talk about our practice, we really start with like the basics, like access. We need to make sure that the primary care community, the referring physicians, and the patients can get access to the cardiologist when they need to see them. And I think that access issue is a big challenge, which results in us only consulting cardiologists after something bad has happened. So we're not really like, if you talk to most people that see a cardiologist, they've seen them because they've been in the hospital or something.
Right.
Like something has happened.
Mm.
But there's a significant amount of information and data that's come out on like all the new, like much more aggressive cholesterol and lipid management, the whole GLP-1 role in preventative disease for cardiac disease. I mean, there's a ton of work out there we could do. And so I think we start off with the idea of, let's make sure our patients get access.
Okay.
Let's make sure that we are providing preventative care. We have an open line of communication with the rest of the medical community, whether that's primary care or other specialists. And then there's always this, like, I think, sneaking fear, like when I think back to my days as a primary care doc or working with primary care docs, of like, well, I don't want to consult if I consult the cardiologist, they go into this big health system and I never see my patient again. So we also want to make sure that we have a two-way relationship with the referring doc, so that we're not like, we pick up a patient. If we see the patient, we make the preventative recommendations. We don't need to see them all the time. We need to like better utilize our docs in a way. So we do think about access. We do think about preventative care, both for pre-illness or for those that have a diagnosed illness. So I use heart failure, number one cause of readmission in the United States. 1 in 4 chance for a Medicare patient, which are crappy odds, right? How do we then build systems in place? We know when a heart failure patient is going to get into trouble. So what systems can we build into place around transitional care, chronic care management, remote patient monitoring, keeping people healthy, keeping them out of the hospital? So it's really about access, preventing disease. When you have a disease, how do you prevent people from getting sicker and having to use other services?
Yeah. So one of the things that you said that caught my attention immediately is the behavior around access. So there's kind of two challenges, right? Challenge number one is some inhibitors to access, which is bad systems, bad processes, whatever, understaffed offices, things like that. Then there's also the behavior behind when to access your cardiologist. And to your point, if so much of it is preventable because it seems to be, then it sounds like we need to change when we think about having a touch point with a cardiologist. And so, first of all, is that correct? And second of all, how do you go about changing that behavior? Because that's a behavior that has to change kind of system wide, from a patient's perspective, from the doctor's perspective, from a reimbursement, perspective. So how do you approach that?
So I do think, obviously, we have to solve for, one, we have a workforce challenge in cardiology. We clearly don't have enough, and I think that's just going to continue to get worse. We have a healthcare system that's just wrought with inefficiency, from documentation, scheduling time. I mean, it's hard to be a doc. Let's just face it. Like it's just hard to do. So how can we solve, like we work really hard, like our rhythm technology platform. Technology is not the answer to everything. It is a tool that helps solve things in conjunction with process management and like thinking of the whole picture. So we come in and really try to like refine the process so that the physician is doing physician work and not doing things that they don't need to do. So we try to solve by opening access. Like a lot of our docs are all private. So before us, they were managing workforce, payroll, hiring people, negotiating with payers, trying to get paid. We take all that away. So there's just free capacity. So there's the one idea of like, we free capacity. And that's a barrier for people making referrals. Because if you're always trying to refer to cardiologists and you can never get your patient in the door, you eventually are like, I'll just do it myself. So we got to solve for that and make it easier. And then second, we have to find a path where, those patients that need to be, we see a patient, and if we make recommendations and don't need to see them, we send them back and we say, this is how we do it. We build that relationship. Not every patient needs to see a cardiologist every 3 months. How do we build that? And that's where we're trying to move into this whole idea of value-based care, where we can work on different models, work with at-risk primary care docs, figure out how to provide services in a way that really drives the outcome, and just kind of building more of a partnership. Not healthcare is just space. There's not a lot of partnerships in healthcare. It's like I send people here and there, and it's just kind of patients kind of get caught in the middle of it. So free access, make it easier, make it open door, get people in, and then, have an appropriate plan of care that you can work on. And patient, you make recommendations, patient's good, we send them back. Patient has an issue, I put in these services, I let the primary care doc know this is what I'm doing. And you start working through all the pieces of it. So it does become a lot more of a partnership.
Yeah. So I think that, if somebody is an independent doctor, right, private practice, chances are they're private and independent because they chose to do that, and they chose to not get bought up by probably the 4 systems in their area that are knocking on their door every 2 months trying to buy them, right? And so they've kind of chosen that life. And I would imagine there's some resistance to becoming reliant on any kind of third-party organization if you're kind of that mindset. Has that been pushback that you've encountered? And if so, how do you guys get past that?
So that's where we fit into a unique niche in the market, because we're not acquiring or buying practices. They truly are independent. But being independent, you're all by yourself. You're trying to negotiate EMR contracts, hiring. I mean, there's just no scale to it. So we give them all the benefits of a large organization from the scale standpoint in terms of support on those things, but they own their practice. Like I have no motivation to change anything in their practice, like how they do things. Like they make the decisions on it. And so we're not out there trying to cut costs out of their practice or move things around. And so they're oftentimes looking for a solution, but have not ever wanted to give up the ability to decide, for instance, how long they want to spend seeing a patient.
Right.
Or that they don't want to work on Thursday afternoons. Like we just work with them on it. We'll tell them how much it'll cost, like what the economics are and the financial impact, but they make the decision on it. So we haven't had pushback on that. I think that's been the thing that's been motivating a lot of these docs. That's the difference between, I think, a group that does acquisitions or buys. Like I'd say is like, these docs people have been trying to buy these practices for since I was an intern, right? So they've already resisted it. So like being bought is not really what's interesting them, but they want someone to help them, technology tools, be more efficient, help with recruitment, fix the rev cycle, like just do all the components of it, which they get, but they do own their own practice.
Yeah. So I think one of the biggest inhibitors to change is actually going back to the behaviors for a second, but focusing on the doctors is like actually changing doctors' behavior. You can give them the best technology, you can give them the best tools, but a lot of times their doctors can be reluctant to actually utilize those tools. And so, what about that? How are you guys getting through that? What are you doing different? Because there definitely seems to be this very fresh, modern feel to Cardio One. And so how are you getting kind of user success?
So we tried to keep it a simple approach. One of the things that was always infinitely frustrating, and I think a lot of this is based on, I practiced until December of 2019.
Yeah.
So a lot of what we built was built around the things that drove me crazy as a practicing doctor. Like, why do I have to log into 4 different systems to do something? It drove me nuts.
Yeah.
And so we try to make the best process the simplest process, right? So we use one platform and integrated everything into it. So it's actually easier to do it's actually easier for them to do and follow the process than it was logging in a different ways or just not using it, because it's part of it. And that's part of the solution that I think people have struggled with, is like different logins, interoperability doesn't really exist. So we try to make it start with the basics. Every doctor in today's world has to document an EMR and have some way to bill. Whether you're on a value-based or a fee-for-service, like, you have to do that.
Yeah.
So start with that at the core, and then we started layering in services and solutions. And then one thing we've added beyond technology is people and support. So I describe having great technology without training as like having a really fast car and you don't know how to drive. It's like, it's useless to you.
I love that. Yeah.
And so we have a team, a practice optimization team goes in and they will sit with the docs and show them how to use it, and then look at whatever challenge that they're having and then figure out how we can adapt the technology to solve the problem. And that's been the key. I think all too often, like, people get this super fancy device and like all these buttons that they could click, and then people are like, yeah, I don't know how to use all that. So they don't use it.
Yep.
So it's really been the people process of it. And then everything into one platform, so that like when the docs are working, they're in one system, and then everything they can order and send and connect everything in one location, just faster is the best way I can describe it.
Yeah. And one thing I will give clinicians at all levels is that they typically hate technology because every time they've touched a piece of technology has made their life worse. But once you can show them something that's different, once you can show them an experience that actually, optimizes their workflow, saves them time, you'll have them hooked. So I'm sure.
Yeah. So we've shown docs reduction in documentation time.
Yeah.
On the platform, we can demonstrate that. So that's been really, I think, what people like about the technology side of it. And then a lot of the rest of it is just solving for things that takes them away, like from being the doctor. Like, they went to medical school, cardiologists trained for a long time. We need them to be seeing patients, not filling out paperwork. And so we really try to take as much off of their plate as we can, so that they can just focus on the clinical side, which is what we need. And I think all those things come together in a way that's been very productive for our groups as we've gone forward.
Yeah. Now, on the value-based care side, are you actually like negotiating contracts and terms for them? What impact do you have on the transition of a practice to value-based care?
So I would say two things. So one, it's interesting because like value-based care is a continuum, is what I tell folks, right? Like, it really starts off with everything from like pay for performance. Like, MIPS is technically value-based care, where you do certain documentation, and then it scales all the way up to episodics into full pop. So we work with them and we start off on the basics. Like, this is how we do MIPS. This is how we're going to do chronic care management. This is how we do transitional care management. And we haven't gone out and done a commercial contract yet, largely because, in my view, there's a lot that needs to be built in order to be successful. And so we're building a lot of the resources behind it. I think one of the bad raps that risk contracts, value-based care gets to physicians in general is they're like, oh, I jump into it. And they haven't solved for access, like all the basics of it. And then they end up in a situation where it doesn't work. So we've been very deliberate about solving for today and getting all that built before we jump fully into the risk side. Our goal is work through the final kind of expansion of, and that's one of the big, parts of capital use that we'll bring on from the Winrose acquisition is twofold. One is significant build in the Rhythm platform to be able to manage those patients and do a really good job of it, built on experience that I've had on like what works. And second component is relationships with payers and being able to go out and like work with them. So the new chair of Cardio One, the board, is Dr. Jonathan Gavras, who's a fellow physician. So we're a truly physician-led company, which I think is super cool. to have, a doc CEO and a doc chairman. I actually came from that. I was at a company called Team Health, and it was run by physician chair and founder, and it was just an awesome place to work.
Mm-hmm.
But he came heavily from the payer side, Florida Blue, Guidewell, United, and I came from the physician management side. So working with him to partner on like how to navigate the commercial side. Unfortunately, there are no real cardiac specific bundles on the government side, like they have for kidney disease, oncology, and musculoskeletal. We haven't gotten that, so we'll be working through kind of some.
Is it on the docket?
Nothing definitive.
Okay.
Nothing definitive. I think people are all interested. Like, there's a lot of interest in what we could do out there.
Yeah.
But I think it's figuring out how to do it right.
Right. But like large employers, I mean, should definitely be interested in a value-based care arrangement for cardiology. Yeah.
I think a lot of folks are. A lot of cardiologists are employed by big health systems, and big health systems have difficult time with adapting to change and moving quickly. So I think it's just a slow mover. That's why we focused on our independent docs.
Yeah.
Well, for two reasons. One, they make decisions very quickly.
Yeah.
I don't have to go through like a whole committee and everything else. Doc's like, yeah, let's go. Like, I think our fastest contract was first meeting to contract execution was like 3 weeks.
That's awesome. That's crazy.
You'd be lucky if you get the health system to do something you'd be lucky if you get a meeting scheduled in 3 months, right?
Yes.
And then the second idea around it is that the cost of care in an outpatient, fully private setting is substantially lower than a health system because we're doing all of our testing outpatient based. We're not doing it in hospitals. We're lower cost of care. So I think that's really the runway as we kind of build forward.
That's awesome. Wow. So just to kind of sum it up, that what seems to me is, so you're taking these practices that are fee-for-service, but you're optimizing them at a fee-for-service level and preparing them for a transition to potential value-based care by putting in the right pieces for success, right?
Yeah, and people always say that. I mean, I think a lot of here's what I tell everybody: access helps you in fee-for-service world.
For sure.
Access is necessary to be in a value-based care world. So as soon as you fix access, you're actually because the transition to value-based care will be interesting, right? Because it's not going to be like flip a switch. It's going to be 100% fee-for-service, zero, and it's going to be 95/5, 90/10. You're going to have to manage both. But as you think about that, like solving access generates revenue today, makes you get ready. Chronic care management, remote patient monitoring, in-office testing, all good things, better for patients. Oh, you better have them if you're going to be in it. So I think that's where people get into trouble as you try to move into a risk arrangement, is they're not ready for it. And so we're trying to make sure we're ready for it.
Yeah. Awesome. So going forward, so again, congratulations on the Windrose deal. That's $100 million committed to the relationship and investment going forward. So that's a lot to play with, which I'm sure is both a daunting task and super exciting all at the same time. So I guess first question is, how does that feel stepping into this new phase?
It's exciting and it is a little daunting. It's a pretty cool space to be in. I think we're all trying to make sure we stay committed to the kind of culture and vision that got us where we were so quickly. And that's been key, is like sticking to maintaining physician independence, physician autonomy, driving results that like move things forward. Winter has been an awesome partner for us thus far in terms of like really kind of helping us and believing in that culture and driving it forward. And yeah, it's all of a sudden, you live in a startup world and you're we're still very cautious, but we have a much different balance sheet and ability to execute now.
Caution widens a little bit,
Your ability to execute. Remember, going back to, if you have capital, you need to be able to execute quickly. It's the same thing as you take another investor. Now you have more capital, so you need to be able to execute even faster as we go forward. And so, it's a great group. Really excited about the new board that we have on board, largely because we do have Eric Reimer, who's CEO of HealthMap, who does kidney value-based care, is on our board. John Geivers, who I mentioned. Chris Suling, who was an executive at Unified Women's Health, that did Women's Health MSO, is on our board. Nate Snyder, who was a former chair of the board, who was one of the an entrepreneur and launched Ovation Fertility. So we have a great board,
Incredible.
very excited about it. Plus the Windrose guys. So it's we just had our board meeting last week. So we're all like excited about where we're going forward.
That's awesome. That's incredible.
Yeah. One of the things that's come up, that's been really a fascinating endeavor for us is we're being approached by a number of physicians who are currently employed that are just unhappy. Like, I hate it. And they want to go private. And so we're actually working with two pretty large groups to take them from health system employment to private docs, which is going to be, I can't wait to get one of those officially landed and done. But if you think about that, that's actually going completely opposite of the way the world has gone for like 2 decades.
Like total reversal.
They're just wanting more ownership of the things that we talk about, like that any like business owner or executive like want to own derive the culture in their practice and the direction that it wants to move. And like we have docs that want to just have more say in, hey, I want a nurse, not an MA, or I want 45-minute visits, or I want to do this. Like I want my practice to focus on preventative medicine. So I think it's really exciting. We present an opportunity that didn't exist before, because if they were to do that, they were like me back when I first graduated. Like, I don't know, like what's credentialing and enrollment, like what's days and error. I don't understand that. So we prevent an opportunity for them to like move over. And so that'll be an exciting part
that is very cool.
Can't wait to move forward.
That really is what they want. I mean, they were probably dragged into the hospital either because they didn't, or to be owned by a network, either because they didn't know how to run the business, or they were sick and tired of running the business, which both lead to just inefficiencies and a lack of understanding. And you're essentially handing doctors the best of both, which is, keep your autonomy. And we're gonna handle everything with a forward focus push towards value-based care, which will only further align with your mindset and incentives as far as patient care. So I think that's
super exciting.
Yeah. Well, congratulations on everything. I hope that, we'll continue to watch Cardio One. I'm sure you guys can continue to crush it now that you have all that fuel in the tank, and excited to see what 2024 and beyond brings you.
Yeah, it's going to be a fun time. We have a great group, and I think that the other exciting part is now we're expanding the team. We built a great company and launched and did what we did with a really small, super dedicated team, and so bringing 3 people on next week. So it's going to be great to grow it and just continue to scale where we're at.
Well, congrats, and thanks again for spending time today.
Thank you very much. Appreciate it. Thanks, everyone.